morning. My topic is male infertility, functionality, and surgery. I work at the Department of Urology, and my vision is to educate patients regarding our finding on the risk factors impacting fertility, and my mission would be a larger scale education of the population. I have 5 topics altogether. 2 of them are related to sperm DNA fragmentation. One is about testicular tumors, and the other 2 are about prediction of sperm retrieval. The first one is the risk factors associated with sperm DNA fragmentation. It is known that infertility rate is quite high in the developed countries, and sperm DNA fragmentation impacts fertility. There are several risk factors which may influence sperm DNA fragmentation, including lifestyle, diet, obesity, smoking, and so on. Our aim was to investigate the effect and extent of known and suspected risk factors on sperm DNA fragmentation. Our clinical question was, what is the correlation between different factors and sperm DNA fragmentation? And for this, we examined males. We looked at risk factors and compared them to the absence of that certain risk factor, and it was all in terms of sperm DNA fragmentation. Our hypothesis was that there is a correlation between the studied risk factors and sperm DNA fragmentation. We did the search in 3 medical databases and ended up with almost 27,000 articles and extracted data from over 200 articles, and we had data for more than 50 risk factors in total. Just a few words about sperm DNA fragmentation before we move on. It is the only evidence-based functional test that is available. There are no exact cutoff points though, but we prefer it to be under 25%, between 20 and 30% of fragmentation. We might expect adverse pregnancy outcomes, but between 25 and 50% of fragmentation, patients are still eligible for in vitro fertilization treatment. From this, it is obvious that when defining what we consider to be a clinically relevant result, we had difficulties determining it, and we set it at approximately 10% of change or difference for the different groups. We did subgroups based on the DNA fragmentation assays, and also based on the fertility status of the males. These are all the risk factors for which we had data, and in red you see the ones that ended up in the meta part, and the black are the ones that we had less data for. So here are some clinically relevant and also statistically significant results. The first risk factor that I want to show you is the varicocele, and compared to the absence of varicocele, it means a difference in sperm DNA fragmentation of almost 14%. When comparing smokers with non-smokers, it means a difference in sperm DNA fragmentation of approximately 10%. When comparing abnormal glucose tolerance to normal glucose tolerance, there's a difference of almost 14% in mean difference. And when looking at age, it seems to be there seems to be an increase over the age of 50, with a difference of almost 13%. As a conclusion, varicocele, abnormal glucose tolerance, smoking, and increased age certainly increased sperm DNA fragmentation, and we could also see a dose dependency in some cases. Some of the strengths include that we looked at all risk factors that had been studied so far. We had a high number of articles with a high number of patients, but we had no longitudinal studies. We couldn't only look at the effect of one risk factor at a time because there were also others influencing it. We had a low number of studies for some risk factors, and we had a high heterogeneity in every case. As an implication for practice, we can give specific suggestions for each patient based on the risk factors they're exposed to. And as an implication for research, we need more studies for some risk factors, and we would need the establishment of registries. This manuscript is ready, and it has been published in reproductive biology and endocrinology. The next topic is related to the first one. We're looking at the interventions which aim to improve sperm DNA fragmentation. The background is pretty much the same. As we have seen, there are several risk factors which may impact sperm DNA fragmentation. Thus, we need to target each of them differently. Some of the options for the interventions include exercising, varicocelectomy, and antioxidant treatment. Our aim was to investigate the interventions that could potentially decrease sperm DNA fragmentation and thus guide clinicians and patients towards the best interventions that could be applied. The clinical question was, do interventions such as lifestyle changes, medications aiming to increase male fertility, decrease sperm DNA fragmentation? The picture is pretty much the same as the previous one. We were looking at any intervention and compared it to the absence of the intervention or a placebo. And our hypothesis was that by targeting the different risk factors with specific interventions, sperm DNA fragmentation can be decreased. And thus we can increase the pregnancy and take-home baby rates. Here is the flowchart of our selection. We conducted the search again in the 3 medical databases. We had almost 37,000 articles to begin with, and we extracted data from over 80 articles. We did the data extraction, we did part of the risk of bias assessment, and we have some of the figures and tables, and I'm going to show you some of them now. These are the interventions for which we have enough data to go in the meta part: varicocectomy, FSH treatment, antioxidant, lifestyle modifications, and we did subgroups for many things. So just to show you some of the results, the effect of varicocectomy seemed to decrease sperm DNA fragmentation by approximately 10% compared to the absence of this intervention. The effect of FSH treatment decreased sperm DNA fragmentation by more than 5%. The effect of antioxidants had a similar effect, and the effect of lifestyle changes were the least significant. Then the next topic is the non-palpable testicular masses and their testis-sparing surgeries. We don't know the incidence of these non-palpable tumors because they are an accidental diagnosis. We see them on ultrasound, usually when patients come for fertility evaluation. What we need to know about non-palpable tumors is that they are usually benign, whereas the palpable ones are usually malignant. And thus, for the non-palpable ones, we advise an organ-sparing approach. Thus, our hypothesis is that most non-palpable testicular tumors are benign, thus the testes can be spared, and this can spare their fertility capacity as well. We're in the phase of data collection. So far, we have 53 patients, which is a very large number compared to the published data. And out of these 53, we have 13 cases that were malignant. And we're still continuing, including patients. The next topic is the prediction of sperm retrieval in non-obstructive azoospermia via an artificial intelligence software. What you need to know about it is that azoospermia means that there is no sperm in the ejaculate. There are 2 types, obstructive and non-obstructive, the latter being more common, making up approximately 60% of all the azoospermia cases. There are several approaches for the non-obstructive cases, but the best one is the testicular sperm extraction. Currently, we have no means to predict sperm retrieval, whether we find sperm or not, if we do the testicular sperm extraction, but based on our data, these are the parameters that seem to be of interest. The most significant one is total testosterone. And our hypothesis was that success of sperm retrieval can be predicted via preoperative parameters, and thus the implication would be that we can avoid unnecessary surgeries and select individuals most likely to benefit from the surgery. We have 174 patients. There was a logit model that was made for us and also a neural network. And the benefit is that it can be retaught after every few patients, but the current accuracy is 86% already, which is the best so far. And the manuscript status is that it's been written, we need to send it out for internal review. This next topic is pretty much the same as the previous one. We just added an extra step after the diagnosis of non-obstructive azoospermia, but before the surgery, we are doing a shear wave elastography examination. The reason for this is that we found an article based on which both the sensitivity and the specificity of this examination was high, and they seem to have better predictions for not finding sperm during the surgery. And based on our previous result, we seem to be able to predict finding sperm better based on the hormonal parameters that we had. For this, we have both human resources and financial resources, and we have already tested this on 14 patients. And currently we're at the stage of ethical approval. This year we're planning on publishing 3 more articles, and the last one is going to be published next year. Thank you for your attention.
You use antioxidant for treatment. What kind of antioxidant did you use?
It wasn't us using the antioxidants because it's also a meta-analysis, just like the previous one. They included...
What was in the meta-analysis? What kind of antioxidants they used in the meta-analysis?
They used very different ones. So, for example, L-carnitine was one of them, or basically what we did, I'll say here that we did subgroups based on many things. One of them was the type of the antioxidant, but we didn't have, since there is no agreement what type of antioxidant to use or what not to use, we couldn't really merge together one type of antioxidants from different trials. So we either did a subgroup based on just giving one antioxidant or a combination. And usually they use the combination, for example, L-carnitine, zinc, and so on.
I would have a question to your first topic. You mentioned that one of the weaknesses of the team was the high heterogeneity. How can you manage this fact?
What we did was that we tried to do different subgroups. For example, let's say for smoking, we consider the amount of smoking for each patient if there was enough data in the article, but no matter how many subgroups we did, the heterogeneity remained high.
Congratulations on your presentation. You have mentioned the age dependency on the sperm DNA fragmentation, and you have also mentioned the dose dependency. And based on your knowledge and the article have you gone through, what is your opinion about that? What's matter more? I mean that it can be different, the age dependency and the time dependency. So you can be a 45-year-old male smoking just 1 year, and you can be an 18-year-old one smoking 5 years.
Yes. Well, to address this question, we did subgroups again. We looked at age differences from 25 every 5 years. We had enough data to go from 25, 30, 35, 40, 45, all the way until 55. And with these studies that we're looking at age, they usually excluded smokers. So we don't have a combined effect on those. And also to study that question, I think it would be better to have individual data on patients, but we didn't in most cases.
Is there a point of no return? I mean, you have mentioned that the lifestyle changing approach can be a useful tool to solve this problem, but for me, it suggests that there should be a point of no return after there is no hope for this man.
Well, we examined the lifestyle changes in the second topic, but we barely had enough data. We had data only for the exercising. So yoga-based lifestyle, high altitude climbing and so on. But it was again very heterogeneous, and when advising patients to change their lifestyle, what we always say is that they have to start doing some kind of sports at least 3 times a week. They have to change their diet to have a Mediterranean type of diet and quit smoking. These are the most important ones that we suggest.
And maybe you have mentioned, it was just me who missed the info, that the data, what you used for the artificial intelligence project, so where it is coming from?
This is coming from our center. These are only preoperative parameters that we examined, and we wanted to use preoperative parameters that are non-invasive. So there is always a laboratory examination prior to the surgeries anyways, and we included data that we had anyways, for example, the age of the patient, testicular size, but these were the parameters of interest, these endocrine parameters. So it's all our data.
And the accuracy of the data, so it was just coming from the regular clinical database. So it was not a special data collection for this specific project.
It kind of was, but since this project started, we collect data for all patients regardless of their diagnosis this way.
I have 3 questions. If you go back to the first project, I didn't really understand. Maybe I'm just too slow here. If you go back to the model estimates, the forest plot result, the model estimates here. Yeah, I didn't really understand what was the measurement scale here. Can you please elaborate?
Mean difference. We looked at the mean difference, and the scale was percentages. So the percent of DNA fragmentation. So this is why we said that it's from 0 to 100.
Okay, I get it. Okay. And what do you think is the source of heterogeneity if it's not your subgroups? What could be behind that high heterogeneity?
Well, the eligibility criteria were very different in each article. That could be a source of heterogeneity. Also, risk factors weren't very well defined in each case. For example, not everyone specified what they meant by smokers. Or, for example, some patients classified someone a drinker when looking at alcohol consumption if they had at least 1 drink in their life.
These are all observational studies, right?
Yeah. We have no RCTs in this one. We have them in the next one.
I'm not surprised that heterogeneity is huge. The third thing is, it's more a pet peeve of mine. Typically with these AI studies where you have a very good predictive model, it gets published and then it's buried deep into a drawer or a file in a computer. Will you be making these available for practitioners to use, the software? I mean, the model. Would it be available? Are you planning to somehow publish it?
Yes, that was my plan. Maybe not for the first one, not for the initial project, because the accuracy isn't that good yet, as we would want it to be. It's still very good, but not good enough for me at least. And for the second one, with the shear wave elastography, we are planning on making it accessible. Otherwise, there's no point in conducting such a research.
Okay.
I would like to ask that concerning your 4th and 5th project, this prediction of sperm retrieval project. So what do you think about the clinical implication of this project? Because if I imagine an infertile couple sitting in front of me, I can't really imagine a percentage of not getting or retrieving sperm during these operations, that a patient, if I want a kid, that even if I have a really low chance to have a baby and to retrieve sperm based on this operation, I would go for it, even for 1 or 0.5%. So how do you see the clinical implication of this predictive model?
I have talked to the patients exactly about this, and there are patients who say that they wouldn't undergo the surgery if there are low chances of retrieving sperm, but most of them would undergo even if they would tell them that there's practically no chance of retrieving any. From our side, it would be rather like a more informed consent towards the more information towards the patients. They would tell them that, look, your chances of having sperm in your testicle is practically 0. Would you still want to undergo the surgery? But we wouldn't exclude them from our practice. They would not do the surgery just because the chances are low. It's going to be still their decision.
First of all, have you? Of course, you must have submitted these results to journals, but I can't recall, where did you submit those?
Reproductive biology and endocrinology, the first one.
The first one.
Yeah.
Is it under review?
No, it's been published.
It's been published.
Yeah.
I do apologize. Sorry, I was. That is my question regarding still your first topic. That what was the novelty? Because I mean, there were tens of thousands of articles published. There was a very, very strong statistically significant signal. Okay, so it looks like obvious. So nobody has ever published that before, or?
No, because it's a newly evidence-based method. It's been included in the guidelines since 2021. So the tests were available in advance, like 20 years prior even. But before that, it wasn't an evidence-based test. So once it has become an evidence-based test, we decided to summarize all the risk factors.
In general, so can you develop a risk assessment tool, put it this way, which contains all of these? You know, you also already mentioned artificial intelligence. So
I think it's not worth combining it because, first of all, even the artificial intelligence project that we have, it is a very big study. It's very difficult to develop these models, and you wouldn't get any closer to the solution. For example, if someone is a smoker, it's a well-known fact that they have to quit. Why would you want to put it in a model?
now that was what my question about the novelty. So, you know, that is dead obvious kind of thing. So
The novelty is the sperm DNA fragmentation index, not the assessment of risk factors.
okay. Any other comments, questions from the panel? Well, I just one minor comment. In your fourth project, that on your background slide, here, Zsolt Kopa is a very good friend of mine, right? So we went to the same university. We have we spent summer together. But I don't think that azoospermia is his original finding. And whenever you put a quote to a reference to something, to a statement, you should really claim the person who invented it or discovered that. And I don't know this journal Urologia, but even if you read his article, you might find the appropriate reference you should have put there.
It was from a book, though.
I know, a book, but still there should be references. So for future, especially when you go to an international conference, I mean, you shouldn't quote a book, you should quote the person who is responsible for that discovery. Okay?
Okay, thank you.
A minor one to this project as well. It's just a recommendation to have some info about the group of patients from where the data come from. I mean, for the AI project, and this one is the registry. Sorry. So just tell that it's 150 male age range and so on, and
Yeah, I only put the number of patients with
the collected parameters and the accuracy of the data.